Hello once again, everybody. Welcome to case study number 20. This will be a patient with worsening back pain. Very common complaint in the clinic typically. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right hand corner. I really appreciate your consideration to contribute and help offset the cost of these videos. Thank you very much in advance. All right, so we got a 46-year-old white woman coming into the clinic complaining of worsening back pain, and that's been going on for the last 3 months. The pain began as a minor annoyance, but is now interfering with her ability to walk and do things she enjoys. It's no longer responding to over-the-counter ibuprofen, and she's now using her husband's oxycodone to help with her sleep. The pain is now constant and is not worsened or improved by anything. She has a past medical history of stage 2 breast cancer, that means cancer plus nodes, at age 43, which was treated by radiation and chemotherapy. She doesn't drink, smoke, or use recreational drugs. She's sexually monogamous with her husband. Medication include anastrozole, paroxetine, and a multivitamin, and her vitals are within normal limits. All right, so what is our differential for chronic back pain? Well, we should first do our physical exam. General, she's no apparent distress. Skin is fine. Chest and heart are normal. Abdomen soft, non-tender, non-distended. Okay, now we get to our abnormal findings. So there's point tenderness over the lower thoracic spine. Range of motion restricted on spinal flexion due to pain, negative straight leg raise, and intact peripheral pulses. Neurologic, she's got reduced sensation around the lower abdomen and umbilicus. She's got hyperreflexia and a positive Babinski sign. So obviously it was very important to do this physical exam. You will be expected to tick off your physical exam preferences, what systems you want to do during your exam. Okay, so now what is our differential? Well, this is a pretty broad differential. We're talking about chronic back pain, but we can we can kind of eliminate some things based on the fact that she's got spinal tenderness. And when I say spinal tenderness, I don't mean back tenderness. I mean tenderness on palpating the spine itself. Okay, so if you palpate the muscles around the spine, well, that can happen with lumbar strain. But if you start palpating the spine and that is tender, then you need to start thinking about things like fractures, spinal stenosis maybe, metastasis to the vertebrae. And so that's much more problematic. Then you start adding in those sort of upper motor neuron signs, lower motor neuron signs. You have to start thinking about cord compression. All right, so our initial workup is going to be imaging. Everybody with spinal tenderness gets imaging. If they just have muscle tenderness, possible injury, think they pulled a muscle, then you could probably send them home on NSAIDs with a diagnosis of lumbosacral pain. So basically the way you're going to go about this, so you have chronic back pain. If it's muscle tenderness, then we can pretty much diagnose it as lumbosacral pain. This is assuming they don't have any neurologic signs or anything like that. However, if you go on and you find vertebral tenderness, and I'm sorry, the neighbors are doing some housework right now. If you have neurosymptoms, so I'm talking here numbness, increased deep tendon reflexes, positive Babinski, then you need to do imaging. And imaging will help you, but you should have an idea of what you're probably dealing with. So this is probably cord compression. And so some things you're going to look out for: positive straight leg raise. That's a sign of herniated disc. If they've got all these symptoms plus what looks like claudication or peripheral artery disease, where they're walking and it becomes painful, you need to think of spinal stenosis. And if they've got a fever, you need to think of an abscess. If they're a young patient, you need to think of things like the spondyloarthropathies and transverse myelitis. And then I'll just add here, if they've got a history of cancer, you need to think of things like metastasis. Okay. So we get the chest x-ray and the spinal x-ray because we're thinking of the possibility of metastasis. The chest x-ray shows a 2-centimeter mass on the left lower lobe, which was not present on the chest x-ray from 2 years ago. Spinal x-ray shows destruction of the T10 vertebral body. That makes sense. She had neurologic signs along the umbilicus, which, as you know, is in the T10 dermatome. So the preliminary diagnosis is spinal cord compression secondary to metastasis. You may at this point decide to treat her with steroids. It's possible on your multiple choice questions, they may go right into that. Once you think it's cord compression, you should treat with steroids. The further workup, though, is going to be to look for other metastases. So anytime you're looking for metastases, you want to get a CT of the chest, abdomen, and pelvis. And then we're also going to get a spinal MRI. And what does that show? Liver and lung metastases. The MRI shows replacement of bone by the tumor causing cord compression at the T10 level. So our management is going to be steroids. That's going to help relieve the swelling, and then radiation therapy to get at the metastases. We want to reassure the patient. She's going to be referred to oncology, orthopedic surgery, and because she now has stage 4 breast cancer, we need to refer her to palliative care. Advanced directives would be timely in this scenario, but you need to be sort of tender about it. Alarm symptoms with back pain, just really think of back pain that does not go away, back pain that doesn't respond to NSAIDs, back pain that's bad with rest, bad with sleeping, wakes you up at night, and then obviously anything with neurologic symptoms. Keep an eye out for patients who have a history of cancer because metastases are particularly common in some of the more common cancers like breast cancer and prostate cancer. Common differentials, as we mentioned, lumbar strain, number 1 cause. This is muscle tenderness, not vertebral tenderness. Compression fracture, look for a patient with a history of osteoporosis. Little old ladies, they get shorter. Sacroiliitis, look for younger patients. The spondyloarthropathy, I have a case study where I go over one of these cases. Herniated disc, look for lower extremity pain and a dermatomal distribution. This is a positive straight leg test. It's often relieved by rest. Spinal stenosis, this causes peripheral artery disease-like symptoms, so claudication, numbness. It's worse when walking downhill, that's classic, and it's relieved by sitting, not spitting. Spinal epidural abscess, look for back pain and a fever. This typically doesn't happen in normal people, so look for IV drug use and immunocompromised people. Transverse myelitis, bimodal distribution, teens and 30s, so look for a younger person. Metastasis to the vertebrae, look for a history of cancer. So to recap, the most common cause of back pain is lumbosacral strain, which has muscle tenderness, but spinal tenderness is absent. That's a diagnosis of exclusion. So the common causes of worsening back pain include cord compression, which will have vertebral tenderness, history of cancer, or trauma. Trauma can lead to a hematoma, so that's something important to keep an eye out for. Epidural abscess, look for a fever. Spinal stenosis, classically worsened by walking downhill. It's improved with rest, and unlike peripheral artery disease, they'll have intact tibial and pedal pulses. Remember to image all patients with back pain and spinal tenderness, get a spinal x-ray and or MRI, and remember that patients with signs of cord compression will need immediate steroids. And obviously treat the underlying cause for whatever is there.